Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. I would really appreciate it if you could go to your podcast app, Apple Podcasts, or wherever you listen into the podcast, and give us a ratings and review. That way more people will find out about our podcast. Also, if you go to my YouTube page, you can find a video version. And if you go to my website, you can find detailed show notes and a complete transcript. Today, our topic is the effect of thyroid health on metabolism. The thyroid is the master regulatory gland, and it's found in the front of the neck below the Adam's apple. The thyroid produces three main hormones, T4, T3, and calcitonin. Calcitonin plays a role in regulating blood calcium levels. T4, known as thyroxine, and especially T3, triiodothyronine, which is a more active form, affect metabolism, appetite, gut motility, heartbeat, breathing rate, the mitochondria, and many other functions in the body. Too little thyroid production, what we call hypothyroidism, including Hashimoto's autoimmune hypothyroid, which accounts for 90% of cases of hypothyroid in advanced countries like the US and Canada, can result in weight gain, a lack of energy, brain fog, feeling cold, constipation, hair loss, infertility, etc. Too much thyroid production, hyperthyroidism, including Graves' autoimmune hyperthyroidism, will speed up the metabolism and cause weight loss, etc. Today, we plan to dig deeper into how thyroid works, how it affects our metabolism, and the interaction between thyroid and liver health with our special guest, Dr. Fiona McCulloch. This will be my second time getting to chat with the beautiful Dr. Fiona after she made an appearance on Rational Wellness last year in episode 65, in which we focused on polycystic ovarian syndrome. Dr. Fiona McCulloch is a naturopathic doctor and founder of White Lotus Integrative Medicine in Toronto, Canada, serving thousands of women with hormonal conditions. Dr. Fiona has written a best-selling book, 8 Steps to Reverse Your PCOS, which offers well-researched methods for the natural treatment of polycystic ovarian syndrome. Thank you, Dr. Fiona, for joining us here today.
Thank you so much for having me on your show again, Dr. Weitz. It's great to be here.
Good. So why don't we start off talking about what thyroid is, what it does, and what its importance is?
Absolutely. So a lot of my practice is dedicated to treating thyroid issues, even though most of my practice is women's health, I would say about 50% of that is treating thyroid health.
Okay.
So it's a huge thing, and it affects so much about our health. So the thyroid is a gland. It's shaped like a butterfly in the neck, as you were mentioning, and it's actually responsible for running the metabolism in every single cell in the body. So this tiny little gland is basically running the show for a lot of different things, including how our brain works, how we expend our energy, how our immune system works, and how all the rest of our hormones work. So this is a really powerful little gland that can easily have problems. So it's definitely one of the most common hormonal conditions that we see in the clinic.
Great. I've always wondered, why does the thyroid primarily produce an inactive form of thyroid hormone T4, and then it has to get converted into T3?
That is such a great question. And as we've been doing, more and more research into this area, what we're learning is that the way that the thyroid hormones are converted from the inactive hormone, which is mostly what the thyroid gland makes, to the active hormone, it actually happens differently in different parts of the body. So in different cells, there might be different things happening with the conversion of T4 to T3. So it's a very intelligent mechanism that our tissues know what they need and they convert as they need. So that, storage hormone that's coming out, it's our tissues that have to know what to do with it. And sometimes that goes really well in healthy people. And then at other times, not so much.
So in other words, each system of the body, each organ converts T4 to T3 as needed for its particular needs?
That's right. Yeah. So most of the conversion happens inside the cell, and these conversions are independent in many ways of other things that are happening in the body. So it's very complicated what causes that. And, there are certain people that have a lot of trouble converting, and I can talk later about what those reasons are, but we're learning more and more about why this is. We know there's been a lot of people who've had thyroid disease, who are on medication, who've just never, ever felt the same since they've developed the thyroid disease, despite the fact that they've been treated and everything's, normal.
So where is most of this being converted? So you're saying it's in every cell in the body? I thought it was primarily in certain organs like the liver and the gut.
So it definitely happens more in certain organs, like the liver is definitely a big one. But, we see this happening in the brain, immune system. So all the different cells have different needs for metabolic energy. And for example, even our fat cells. So I was reading a study the other day that was showing us if you take a fat cell and you expose it to cold, that fat cell will then start producing T3 in order to, generate heat and energy. So it becomes hyperthyroid inside that fat cell.
Really
so
interesting.
Yeah, it's pretty interesting.
So that could be another mechanism for why getting exposed to cold has a beneficial effect. Normally we hear about being exposed to cold increasing brown fat production, which is metabolically active and helps us burn calories, but it sounds like it has a direct effect on thyroid.
Yeah, exactly. And that's actually part of how that whole thing works, is by using the thyroid hormone to generate what we would call like a sympathetic drive. So that kind of fat burning, energy producing mechanism. So it's really the thyroid hormone that's involved in that. And that's why a lot of people, when they are hypothyroid, they feel very cold all the time. And their basal body temperature gets really low. And when you correct that, you'll see that their temperature gets much better.
Right. Yes. And you see it more commonly in women who get cold easily and, tend towards a little hypothyroid. So
yes.
How do we measure thyroid? What are your favorite tests and what do you think is the most important measurements of thyroid?
Yeah, so I'm so happy you asked this, because it's definitely one of the number one problems that we have today in understanding the thyroid. So
I've heard some doctors, even a prominent functional medicine doctor, say just TSH, that's it, end of story. You don't really need to worry about anything else.
Yes, exactly. And so this has been sort of the standard for years, that we only need TSH, which is really the hormone that the pituitary gland makes. And TSH basically tells our thyroid to make mostly T4, which can then trickle down into T3. But the TSH is supposed to be the regulator. And it is true in that it often is a leader in showing you problems with the thyroid first, before you'll see that sometimes with the other hormones, but it's not going to give you all the information. So we know from research, for example, if a patient is hypothyroid and then you correct their TSH within, when you correct it to, 1 point or to 2.5, what they find is that there's actually not a lot of difference with the person's energy expenditure at those different levels of, correcting the TSH and getting their T4, levels optimized. But what they find is that there is still a deficiency in energy expenditure compared to people that never had a thyroid problem. So there is something where the tissues can still be hypothyroid, even if the TSH is normal in someone who has a thyroid condition.
Wow, interesting. So what exactly is happening there?
So probably, the vast majority of what is happening is that the T4 is really not being converted in the cells very effectively into T3. And there's so many different reasons for that. So some of the reasons we've known for some time involve things like illness. So they've known for a really long time that when patients get sick in the hospital, their T3 levels go down, and their levels of reverse T3, which is like an inactive kind of hormone that our body turns T4 into, those levels go up. So when someone is sick, so they could have inflammation or an infection or be, sick from a surgery or something like this. So their T3 will go down. And this is just the body's way of preserving the energy and, protecting against energy loss when you're sick. Other things can do that as well, like stress, for example, or nutrient deficiencies like iron deficiency. And there's also, interestingly, some genetic polymorphisms in some of the deiodinase enzymes. So those are the enzymes that convert T4 to T3. There's 3 different enzymes, D1, D2, and D3. So D1 and D2, those 2 are the ones that convert T4 into T3, and especially D2, it does most of that. So when we're converting, this enzyme is responsible for most of that. And then D3 turns T4 into the inactive reverse T3. So what they found is that about, I believe it's something like 5 to 15% of people have a genetic polymorphism in D2, meaning that they can't convert T4 to T3 as well. So when you're, giving, T4 hormone or, Thyroid, for example, which is the most commonly prescribed medication, there are many people, no matter what they take, they're just not going to convert it the same way. And the way that that's given is not exactly the same as all the complex regulations the body would do if it was healthy, because we're actually giving a hormone. So for that reason, some people, they just don't convert that well and they still have symptoms.
Interesting. Since a lot of this conversion is happening in the cells, I wonder if even serum levels of T3 are necessarily even going to reflect this.
Yeah, so it is thought that the serum free T3, because it's a free hormone, does to some degree mostly correlate to the intracellular levels. Because we do see that people's energy expenditure rates, when they're looking at people in a metabolic chamber where they're controlling everything, when their T3 goes up, their free T3, their energy expenditure goes up. So there is some kind of correlation there, but there's all kinds of other things that we are not seeing. You are so right. And so many things that we do not even understand at this point.
So are these genes, these genetic polymorphisms for D1, D2, and D3, are these part of a 23andMe or Ancestry panel?
I have not seen them on there. I would have to revisit that and look again, because I haven't looked at what they have recently. But as I looked, the last time I looked, I did not see them on there.
So do you test those?
Well, in Ontario, where I practice, we are not allowed to do genetic testing here. So, I used to do that back a while ago when that was allowed, but my background is in molecular biology. So, we are not allowed to do that. But patients can do that on their own, with 23andMe, for example. So.
Oh, okay. Yes. So it's part of 23andMe. Okay.
Yes. Yeah. I'm just not sure if those are in there or not, the deiodinase polymorphisms, because I just haven't looked recently, but it would be interesting to know.
I'm going to have to check. I know in the last year and a half, 23andMe is not testing as many genes as they were before.
I know. They took some off their panel, some of the bigger ones,
they used the less advanced method of testing, unfortunately. So apparently Ancestry might be a little better for some of our purposes.
It'd be pretty interesting to see that. And I think also the other way that I really notice it is that the patients are taking, T4 medication, and, you check everything, you get everything fixed for them. You fix their iron levels, do everything you can for their sleep, their adrenals, their stress levels, their diet, and they're still not converting T4 to T3. So they've got high T4 and low T3. Then my guess is it's probably one of these polymorphisms that's involved there.
And so, what do you consider a high T4 and a low T3? Is it outside the typical range, or is it more nuanced than that?
The way I look at it is, where are they in the range comparatively to each other? So like, is the T4 up at 19 and the T3 is down at the bottom of the range at 3, then we know for sure they're not converting.
Right.
If they're around that same level, it looks like, they're most likely converting. But there's a large percentage of people, I would say, especially the people that are on a lot of Synthroid. So they're on a very high dose of Synthroid. Many of them are not doing well on that medication because they're raising their dose to try to improve symptoms. And, they just end up accumulating a lot of T4, and it's just all, trickling down into reverse T3. So those levels on the panel can really tell you a lot. Just, the TSH, free T3, free T4, and reverse T3. And then looking at that compared to if they're on medication or not, you can get a lot of answers from that.
Interesting. So what's your complete thyroid panel consist of besides TSH?
So I definitely include TSH, free T3, free T4, reverse T3, and the 2 thyroid antibodies that I do most commonly are antithyroglobulin and antithyroid peroxidase. Okay. I also sometimes do the TRAB, which is a thyroid stimulating antibody that you'll see more in patients who have hyperthyroidism or Graves. So if I see anything like that, I'll definitely run that as well.
Is that the same thing as a TSI, I think they call it in some of the labs here? Okay.
Yes, exactly.
So now when it comes to TPO enzymes, what level are you concerned about? So this is an indication of autoimmune hypothyroid. I've heard one prominent functional medicine practitioner say, well, basically, if it's under 500, you don't really need to worry about it.
Mm-hmm. So, I kind of look at it at first I look at the patient, and I'm like, is this person well, or are they sick? Are they experiencing thyroid symptoms? Are they having brain fog, fatigue, weight gain? Do they have like a low body temperature? They're feeling depressed and they weren't like that before. And then I look at the panel and I see like, how does their function look? And then I look at the antibodies. Now you can see some people with really high antibodies that are totally fine, which is always interesting to me.
What do you mean? What level antibodies are you talking about?
I even have some patients, who are doing really well, but they have, maybe in the hundreds, and they have no symptoms, it's founded incidentally, their levels look great. So for me, it really matters if they're sick or not, Right. And then the more sick they are and the higher the antibodies are, the more concerned I am about that. And especially if I see the antibodies jumping, especially in the order of like 100 or a couple hundred, or going from something like 50 to 300, then I know something's going on there. So right. I think, I am like, if they're in the tens, like up to like 50 or so, many people like this can have a more mild type of Hashimoto's. But if their thyroid's really hypothyroid, maybe there's more going on than we're seeing with those antibodies, and they are, they have more damage to their glands. So I find the antibodies are kind of, they guide, but they don't tell me as much as, looking at those hormone levels and correlating that with the patient's overall like history and, how they're doing with their health. So I kind of take it all into consideration.
Yeah, I think some of the labs say under 30, they consider that normal.
Yeah, yes, anything under like around 30. I don't know if you guys use the same units, but yeah, around 30 for the TPO is considered normal. And, everybody has some of these antibodies, it's, you don't see anybody with like none. So right. I don't tend to see people at that level, below the reference range or really having, I don't see that as an issue really. Right. If it's a mild elevation, like sometimes I'll see that for women who've just had a baby, and then, that can go back down, and that can go away. But when you see the people in the hundreds, that's probably not going to just disappear overnight. So usually those people have to manage it for the most part. There are the rare cases that don't, but most of them do have to manage their Hashimoto's ongoing.
So let's say a patient comes into you and they do have some hypothyroid symptoms and they do have elevated antibodies, let's say not super high. Let's say they're, 150 or 200 or something like that. And what is your rationale? How do you think about this? How do you try to drill down and try to find some of the underlying causes of what's going on here besides simply putting them on thyroid?
Yeah, so the very first thing I'll do is, if they're having those symptoms, I'll try to see, do they have low T3 or are they not converting well? And then I'll start looking at all the reasons they might not be converting well. So I'll take a look at, their cortisol and their sleep and their stress, because that's just huge. I'll also look at another good example is if people lose a lot of weight, their T3 will tank at that time because of the weight loss, and the body is just really trying to conserve energy. And this all happens because leptin actually has a huge impact on pushing back on the brain and causing us to actually, not burn fat, basically. So that mechanism there is a huge part of why people, once they lose weight, they hit the plateau. So I always look at that. Did you lose a lot of weight recently, or did you do, a major change to your diet? I'll check their iron, their vitamin D. I'll check their blood sugar to make sure they don't have, diabetes or prediabetes. I'll check their HSCRP to see if they have inflammation. I'll look at their CBC to see if they have any signs of an infection. So I look for all the things that might be kind of like that the brain is trying to lower the thyroid about, and try to fix those things because that's the underlying cause of the problem. But if they have, these antibodies that are high and, you're working on everything else and you're still seeing that problem, I'm always going to look at, providing the nutrients the thyroid needs, because with the antibodies, you're going to need a lot more selenium. Zinc is another important nutrient as well. So I look at, making sure the person's sufficient in those nutrients and they're not deficient in anything really important. And also that they have what they need to protect the thyroid gland from oxidative stress and damage from these antibodies. So the selenium is really important. I also tend to minimize iodine intake if they have, recently elevated antibodies or a big spike in antibodies, because those can be a bit of a trigger too. So I just tend to make sure they're not consuming kelp or anything else that might be kind of triggering up the antibodies. And then I look at, their gut and make sure that there's nothing triggering infection with their gut, or infection or inflammation. They're having some kind of reactions to foods. Do they have a gut infection of some sort, dysbiosis, yeast, or bacteria, or something else, really happening with their gut that's aggravating their immune system? So I try to look at the autoimmune part that way. And then once I've taken care of all of that, then I might consider looking at natural desiccated thyroid as an option for some patients.
So you prefer using natural desiccated thyroid versus synthetic T4?
I think if certain people are doing very well on synthetic T4, that's totally great. If your cells work well enough to convert it, fantastic. I think that's a great sign of being really healthy. Unfortunately, most patients with Hashimoto's are not in that boat, and they're kind of, they've gone through a lot, like just they're not feeling well. That might have disrupted their sleep. It might have caused stress. They might have other hormone problems. So those patients tend to do better on the desiccated thyroid because it doesn't require every cell to convert T3 exactly, right on point, as, would be great if we all could do that, but not most people who have Hashimoto's are not feeling well. So not so much in that case.
What's your preferred desiccated thyroid product? And there seems to be some issue these days with Armour having maybe changed their formulation and some of the products being difficult to are on back order.
Oh, yes. So we have that problem here too. So in Canada, we have only one product, which is pharmaceutical called, so we don't have Armour and we don't have Nature Thyroid.
And Nature Thyroid, no?
No, we don't have WP or anything, but we do have IRFA. IRFA is great. It's actually a really good desiccated thyroid product. So I actually really like that. And I know a lot of Americans do order that from here, but we are having the same issues with the shortages, which appear to be raw material related, because I've spoken with the manufacturer. So it's really like a worldwide raw material shortage that seems like it will be improving soon, but it's really come from that all these deficiencies, and that's why all of the different companies have become, have run out of stock around the same time.
So the reason you like the natural desiccated thyroid is because it essentially is a combination of T4 and T3. Is that the main reason why, or are there other reasons as well?
That is the main reason. And I also feel that it's, the other thing that it has the other thyroid hormones in there, like T2, for example, which we're learning does play a role in cholesterol metabolism. And you'll just see night and day changes with patients when they switch from, a T4 medication to desiccated thyroid. And there's very consistent ways that we dose it and tweak people's medications. So at my clinic, we're pretty experienced with doing that with the desiccated thyroid, and we have really good results. So we tend to get more of the patients who aren't feeling well on Synthroid. So I think that they're coming to us for that reason. So that tends to be my preference, probably because I'm already getting the patients that are not doing well in the first place.
Right. You mentioned nutrients and you mentioned iodine, and there are some docs out there recommending super high dosages of iodine. Typical amount of iodine recommended per day is typically 100 to 200 micrograms per day, and most multivitamins are somewhere in that range. And yet there are products on the market that have 12 or 25 milligrams. So that's thousands of micrograms. And some doctors claim they get really great results with that. I've tried it on some patients that weren't doing that well, and I haven't seen good results with it.
Yeah, this is a super controversial topic, and I totally agree that, these higher dose iodine, they've been around for quite some time, as well as the testing for it, and I agree there's probably people that do feel well on this. There's lots of people who report that they do. I have not seen that either. I agree with you. I haven't seen patients improve, and I've actually had patients come in who've done this, on their own, maybe, the really high dose milligrams of iodine, Lugol's, for example, and, ended up with really bad flare-ups of their antibodies and, even thyroiditis and hyperthyroidism. So, and we do know from some of the population studies that populations that increase their iodine intake, they have increased levels of antibodies. Hashimoto's is actually even named for an area in Japan where there is more of this iodine intake. So it's just something I have not seen personally to help that much. And to me, it's potentially risky. And I have seen patients who were intaking iodine in medium amounts, maybe not as high as these really high milligram amounts, but when they cut back on the iodine, their antibodies have gotten better. So I know we have, a lot of information in the literature that high dose iodine is definitely going to be aggravating to many people. It's difficult to predict who those people are. So I tend to go towards the treatments that I know are safe and effective and that I have more experience with prescribing.
Have you looked at the other products, halides? So these are elements in the same category as iodine, like fluoride and bromine and chlorine. And some have claimed that these can negatively affect thyroid by interfering with the iodine. Have you looked at that, or do you have an opinion about that?
I agree with that. I think that can be an element where you can see that these elements will interfere with the uptake of iodine and the utilization of iodine. So that could potentially be true. There are some tests where you can check for urinary bromide, for example, and fluoride and see, if you're being exposed to that. You would want to make sure you're not deficient in iodine if that's the case. But it's very difficult to know that, without doing this testing, and then to give iodine and assume that these negative reactions are a detox type of reaction. We just don't really have evidence that that's what's happening, because there are a lot of people that have reactions to iodine, and they're not feeling well. And, but people are saying, this is a detox reaction. We just don't really know. It could be the iodine aggravating the patients, because we know that this can happen too. So I do believe there is some, definitely the fluoride is not great for our thyroid, and bromide.
You have mandatory fluoride added to your water up there in Canada?
Yes, we do. Absolutely.
Yeah, and a lot of our water has chlorine. I know in Los Angeles, where I am, we have chlorine and ammonia, both added as antiseptics.
Oh, ammonia. That's not good. We have
chloramine, Yeah.
Yeah, I don't know what we have. I have a reverse osmosis on my house.
I use that too. Yeah.
Yeah, because I just don't even want to know, what is going into the water supply.
Absolutely.
And one day I moved into my new house, and there was a lot of rain, and I had my tap on, and I smelled this like chlorine smell, like so strongly coming out. And I was like, this is crazy. Like, how is this coming out of my tap? And then I was talking to someone and who works in the city, and they were saying in this area, if there's a lot of, because we're on the lake, if there's a lot of, rainfall, they'll shock the water supply with chlorine to get rid of organisms. And so that's what that was.
Yeah. There go the organisms in your gut, right? Bye-bye microbiome.
Yeah, I figure it's got to be bad if your tap water smells like bleach. Like,
yeah, not good.
Intense.
Yeah, you probably could have lit it on fire, right?
Yep. So then I called up a water filtration company, and here we are.
There you go. So talk a little bit about reverse T3. I saw you had an article about reverse T3 and why that's so important.
Yeah, so reverse T3, it's one of the hormones that is inactive. So we have the T4 that can turn into either T3 or reverse T3. So T3 is the active hormone, and reverse T3 is the inactive hormone. So when people learned about this, I think something happened on the internet where people started to almost villainize reverse T3 as this terrible hormone that we must eliminate and get it down.
And everybody said you have to look at the free T3 to reverse T3 ratio, and that was the true marker for thyroid health.
Yes, exactly. And then another trend that happened was if your reverse T3 is high, well, what you must do is give T3 medication to force it down.
Exactly.
And often in very high amounts that this has been done. And it's really ignoring the wisdom of the body. So the reason that the reverse T3 is high is because your body wants that to be the case. It's choosing to do that because it's saying there's something that it wants to conserve energy around. And I think before we can say that we need to lower this reverse T3, we need to figure out why is it like that and help the patient overcome that. And reverse T3 does not compete with the T3 for the T3 receptor. That's been proven. So it's not a competitor. It's just a product that your body is using to kind of get rid of extra hormone it doesn't want or need. And we've also found in new research too, reverse T3 seems to have, functions that are on the immune system that are related to times like starvation or illness. So forcing that down is, in my opinion, pretty risky, especially if you don't really know what's happening. And I've seen a lot of patients, taking all this T3, they end up, with palpitations or arrhythmias or not feeling well, just kind of stressing out, getting yourself into that flight or fight stimulated state. Sure, you have energy, but it's not good for your health to be in that kind of amped up state all the time.
Yeah. You mentioned that people who have a lot of sudden weight loss will see a decrease in their thyroid function. So can people with normal thyroid, just because they lost a bunch of weight, all of a sudden be suffering from hypothyroid?
Yes, absolutely. And the thing with that is that the thyroid gland is totally fine. It's more the peripheral conversion. So the the fat cells, they start burning the fat. The fat mass decreases, and then our fat cells are like, oh, I think we're in a famine, maybe, because these are very primitive parts of our brain. So the fat cells are now like buckling down and like conserving all the energy, and that part of how they do that is actually by deactivating the thyroid hormone. So changing T4 into reverse T3. This happens in healthy people who have no thyroid problem. But it's not really that their thyroid is involved. It's more that the cells are doing this to conserve energy.
So what do you do about that if you're trying to lose weight and now you hit this sticking point where your thyroid is slowed down, or the conversion of T4 to T3 in the periphery is slowed down?
Yeah, it's a really good question. So firstly, we would want to do anything we can to optimize that conversion and take away other stressors. And I always say for people, the worst time to lose weight is especially due to anything drastic, is if you have stress or a lot going on, or you can't get enough sleep. Is there
anybody who doesn't have stress?
Yeah, so no, but yeah, it's you want to do it at a time that your life is somewhat normal. You're not doing something really super intense, like releasing a book, for example, may not be the best time.
Or trying to lose weight.
Yeah. So basically, we take care of everything else that could also be contributing to that first. And then, there's different methods that you can use, for example, with exercise, to just increase your metabolic rate, ways that you can increase your mitochondria so they'll burn more energy. So those I always prefer to recommend first. And then there are some patients who do benefit from a little bit of natural desiccated thyroid when they get really stuck. And so in those patients, as long as everything else is taken care of and that's not going to be a stressor to their system, it's something that I've done for patients and it's been really helpful for them.
Is that something that they're now going to have to take the rest of their life?
Not usually. So it really depends. Good. Yeah. So it's more, when they get to the weight they want to be at, especially if they're able to, increase their muscle mass or do other types of methods to make sure that they do kind of keep their metabolism healthy, then, that small amount might just be there to help them get through that plateau and improve further with their metabolism. But yeah, these would be very tiny amounts, not, clinical, like the higher clinical doses we would see in hypothyroid patients.
So like what dosage are you talking about?
Maybe 15 milligrams. Okay. The standard starting dose is between like 30 and 60. So, for the patients that have that really real weight loss resistance, just like a little bit, because their T3 sometimes can be like really, really low and they start getting really cold. And so, we do that along with everything else that we can. So getting their sleep and their exercise and all dialed in too.
And when you have a patient who needs some thyroid support, how often do you find that they also benefit from some adrenal support?
Pretty much every single time. Yeah, I don't think there's any, because the other thing too is that having a thyroid condition is really stressful. It just affects so much. So it affects your brain a lot. A lot of people don't realize like how much it affects our brain chemistry. We can have depression, anxiety. People have never had these issues in the past, just develop them. So this causes a lot of disruptions to sleep, which really affects the adrenals, or you can have anxiety, which really affects the adrenals. So just having a thyroid condition is a stressor. And then, treating the thyroid as well, it can take some time. And so giving the person that extra stress relief and helping them, their adrenals to be healthier, helping their brain to perceive stress more normally and have less kind of cortisol reactions to stress is always very helpful for thyroid patients.
So what's your favorite way to support the adrenals?
Oh, I have quite a few. I guess one of my favorites would have to be ashwagandha, if we're looking at a supplement, because it's so multi-purpose. I find many people respond really well to ashwagandha, whether they're hyper or hypo. It's nice and calming, so it's not overstimulating. And then my other favorite would really be, keeping blood sugar under control. A lot of people don't think of that as something that relates to the adrenals, but every single time your blood sugar drops, your cortisol goes up. And so when you run people's cortisol, a lot of the time their cortisol will spike in the afternoon above the range, and it's because their blood sugar dropped at that time. So it's just one of those little things that I've learned that makes a huge difference for people's adrenals.
So how do you keep their blood sugar from dropping in the afternoon?
So I just make sure that they have a really good lunch with a lot of, a serving of protein, so about the size of the palm, 2 or 3 cups of vegetables, a nice serving of healthy fat, so something like a half of an avocado or a closed handful of nuts or seeds, and then just keeping the carbs on the lower side, so like a half of a cup of carbs, for example, and then choosing carbs that are more slower burn. So, you could look at resistant starch. So something like, for example, white beans have a good amount of carbs, but they're high in resistant starch, which really stabilizes blood sugar. Or you could look at, sweet potatoes, as a tuber that is a very low reactivity kind of carbs. So, but really making sure that it's the proteins, the fats, and the vegetables are dialed in, and then just keeping the carbs from running the show. That really stabilizes blood sugar for many, many hours.
How does the thyroid interact and affect the liver?
So the thyroid actually has a huge impact on the liver. Some of the different things that it does, one of the big ones is regulate cholesterol production. So the liver, produces cholesterol, and a lot of this is actually under the regulation of the thyroid. So, for example, if someone's hypothyroid, what happens is their bile actually slows down. So the bile is the stuff your liver secretes. It goes out your gallbladder, it goes through your gallbladder and out into your intestines, and out your body it goes. And there is cholesterol in the bile. And what happens in hypothyroidism is that slows down. And so the cholesterol is actually reabsorbed back up through the liver again. So you're getting more cholesterol is taken back up. The other thing that it does is it reduces...
Oh, that's interesting. So if you're working up a patient for cardiovascular disease and you're trying to control their cholesterol, maybe they have elevated LDL particle number or small dense LDL, and your strategy is not working, you think about looking at the thyroid.
Oh, yes, absolutely. I see so many patients who have high cholesterol. They actually have a thyroid problem. That's
an alternative to simply increasing the statin level.
Yes, because it's not the cause. It's actually, in many cases, I think I saw a study where they were saying 15% of people.
Lovastatin is not the cause of high cholesterol?
Right. Well, yeah, whatever, it's just that's not addressing the fact that their thyroid is low.
Right.
But yeah, so it's super common. I see one of the first things I think when I see high cholesterol is I'm always like, let's look at the thyroid, because a lot of the time, it's that. And
by the way, with men, they hardly ever screen for thyroid.
I know. Yes, absolutely. Like they never do. And it's, if they do, it's just TSH, they're not looking at anything else.
Right. Absolutely.
And a lot of men they're just tired or they're gaining weight, but they're not as likely to mention this, to the doctor. And they're just they're getting their blood. They're like, what's on my blood? Your cholesterol's high, so they don't necessarily think to mention that they're feeling tired or, they've gained some weight, they it's just not something brought up to men very often is hormones, unfortunately. And it really should be.
Absolutely. Yep. So go ahead with thyroid and the liver. So it affects cholesterol and then...
Yeah. And then the other thing is that it's responsible for the production of the LDL receptor. So basically, when someone's hypothyroid, their LDL receptor can reduce by around 50%.
Wow.
Which is huge. So it suppresses the uptake of LDL. And then, of course, you're going to have increased LDL. So that's another way. So it has a pretty profound effect on cholesterol. And then it also regulates the way that the liver produces glucose, and the liver is sensitive to insulin through actually the nervous system that goes from the brain down to the liver. So it has really high level effects on the liver and metabolism too.
Interesting. So, what would we see on a lab test? Like if we saw somebody with like slightly, like the liver enzymes were slightly higher, we typically start thinking maybe they have fatty liver, and so you're saying this can be related to thyroid.
Yes, very much so. And they kind of exacerbate each other. So having fatty liver can reduce thyroid hormone conversion because the inflammation that's there,
right?
So they actually make each other worse. So the hypothyroid affects the liver and causes all of the fatty liver. It slows the metabolism down too. So the burning of fat is lower. So it just accumulates more, less is going out, more is getting taken back up, the receptors down. So it's just a vicious cycle.
So besides lowering the carbohydrate intake of the diet, what other strategies are there for, what are your favorite strategies for combating fatty liver?
So, yeah, I would say 100% diet is the number one strategy for that. But just to go even further into diet, intermittent fasting is fantastic because it really gets the insulin down, allows the liver to really release the extra energy that's there.
And what do you call intermittent fasting?
So it really could mean anything about, going from one meal to another. But what I'm talking about more is, at least 12 hours and maybe like a 16-8 would be the minimum that I would consider to recommend to patient. The 16-8, I recommend those several days a week for patients a lot. Not every single day, but a lot of patients can do that, and it makes a huge difference, with the liver and its function. So that's definitely one of the big ones that I suggest for people.
Are there any nutraceuticals, nutritional supplements that can be beneficial for fatty liver?
Yes, absolutely. So I find, some of my favorites are alpha lipoic acid, because it definitely helps with the insulin resistance as well as provides antioxidants to the liver. And acetylcysteine is another one of my favorites.
Which is a precursor for glutathione, right?
Exactly. The precursor for glutathione. It's used in liver detox pathways. It is anti-inflammatory. It helps with insulin sensitivity. Making sure that there's enough choline as well is really important, which can be taken in through something like phosphatidylcholine, or you can get choline from eating liver or eggs as well. So those can be really key. And, I find as well, just making sure that there's really good antioxidant status. So even something as basic as vitamin C, if you have low vitamin C, your liver will not be functioning at its most optimal. And when the liver is fatty, it's already very congested, and there's so much inflammation and so much additional need for different nutrients that vitamin C is very easily depleted.
I don't want to go down another rabbit hole because we're just about out of time, but you mentioned the choline, and I've had several discussions on the podcast about the current controversy about TMAO being caused by consuming choline. Do you have a comment about that? TMAO is this marker that the Cleveland Heart Lab came up with for increased cardiovascular risk.
Interesting. And I don't know about that study, but is that a certain kind of choline, or is it like dietary choline or supplemental choline?
Both, absolutely. So Stanley Hazen, who developed this TMAO marker, it's on a blood test. It's being offered. I think Boston Heart Lab includes it now. And they're saying this is independent of cholesterol marker for heart disease risk. And intake of from food or supplements of choline, L-carnitine, or phosphatidylcholine are all the things that he says you need to reduce. And I have a lot of problems with this concept because those nutrients are super helpful and healthful, and we found choline super beneficial for the liver, and L-carnitine another super beneficial nutrient, including for patients with congestive heart failure. So it's really hard for me to buy into this TMAO hypothesis, but it's a point of controversy right now in discussion.
I've never heard of that.
Okay.
Before.
Look it up. TMAO.
Yeah, I definitely will. And I would want to see like some kind of information to show, because we know that the choline has been found in many other studies to be very beneficial for the liver.
Absolutely. And we've seen eggs do not increase your risk of heart disease, which are high in choline. Yeah.
Yes.
One of the
I want to see like what are the elements that are related, and like how is this, pathway, could it be related to something else, and is it directly damaging? I'm just sort of interested to see more about that, but I'll definitely look into that. That's really interesting.
Yeah. Listen to the podcast interview I did with Bob Roundtree. That was one of the things we discussed, but it's come up several times in discussions about cardiovascular risk.
So interesting, because we don't see in population studies that really consuming eggs increases cardiovascular risks. So,
by the way, this is another tool right now for the there's kind of a dietary war going on right now, and we have the different sides. Yes. So yes. I'm not trying to take sides here, but the plant-based side, i.e. the vegan side, is we got you with the TMAO now. So
yes, so it may be there are certain things you can pluck, and
why you can't eat meat and you can't eat eggs, and
Yes, I think we saw that with carnitine in the past as well.
Exactly, carnitine raises TMAO. Yeah, exactly.
Yes, so I will have a read and do some thinking on that too.
Good. Okay. So how can viewers and listeners get a hold of you and contact you and find out about your book and your program? And when is your thyroid book coming out?
I still haven't recovered from my last book, but I'll let you know. But you can reach me at whitelotusclinic.ca. I have a practice in Toronto. We have a clinic where we serve lots and lots of patients with hormone problems. I have a book called 8 Steps to Reverse Your PCOS on Polycystic Ovary Syndrome. I have an Instagram page at Dr. Fiona ND. And I have a blog also at drfionand.com with lots of information. So feel free to follow me there.
Excellent. Thank you, Fiona.
Thank you, Dr. Weitz. It was so nice to talk to you today.
Excellent. I loved it.